Okay, good afternoon, everyone. Today, 26th July 2025, Saturday, from 3 p.m. onwards. I'm Dr. Bhuvan Nagpal, founder president of POPMA, that is Practicing Oral Pathologists and Microbiologists Association, whose sole aim is to promote the specialty oral pathology practice in India. And I warmly welcome all of you to yet another power packed session of POPMA Study Club Multidisciplinary Series, an academic initiative that continues to bring together oral pathologists, medical professionals, students, and specialists from across the country and beyond. Our goal is simple: to empower the diagnostic community and oral pathologists specifically with clinical insight that goes beyond textbooks into the very core of real world practice. Today's topic could not be more relevant. In an age where dental practice intersects increasingly with systemic conditions and medical emergencies, it becomes essential that we, as oral healthcare professionals, stay trained and ready to respond when the unexpected occurs. Systemic emergencies from anaphylaxis and hypoglycemia to cardiac arrest are not rare anymore, and how we react in those few critical moments can determine life and death, safety and liability, or even confidence versus regret in our clinical setting. It is therefore our privilege and honor to host a legend in oral and maxillofacial surgery today, a name that inspires generations of oral surgeons and educators alike. Dr. Nageshwar Iyer sir. Our guest speaker today and a pioneer in oral and maxillofacial surgery with over 35 plus years of total experience, out of which 21 years of teaching experience. Sir has done BDS and MDS from prestigious Bombay University, where he was not just a student but the university topper with 7 subject gold medals. He served as Dean and Principal at Maharishi Markandeshwar College of Dental Sciences and Research, Mulana, which is one of the leading institutions in North India. Dr. Iyer sir is Lifetime Achievement Awardee of AOMSI, that is Association of Oral and Maxillofacial Surgeons of India, from Haryana chapter, a testament to his immense contribution to oral and maxillofacial surgery fraternity. He has 36 national and international publications with over 482 citations on Google Scholar. Known for innovation, he has even contributed to surgical techniques, being the first one to describe the comma incision for third molar surgery, published in the Journal of Oral and Maxillofacial Surgery 2002. His areas of interest span post-trauma rehabilitation, cleft surgery, facial deformities, biomedical statistics, and healthcare management. He currently practices as senior consultant oral and maxillofacial surgeon at Savitri Krishan Memorial Smile Center, Yamunanagar. With his rich academic, clinical, and surgical acumen, there could not be a more appropriate expert to guide us through the management of systemic emergencies in dental practice. So please join me in welcoming with respect and admiration Dr. Nageshwar Iyer sir. Sir, you're welcome, and over to you, sir. Sir, your mic is on mute.
Yeah, thank you so much for unmuting me. Thanks a lot. Thank you so much, Dr. Bhuvan, first of all, for inviting me to this excellent venture. I really admire the courage and pulling in the resources and human resources, especially, to organize such an event. It's really commendable on your part for taking up this venture. Thank you so much once again. And I think I'll not take much of your time. First of all, let me tell you that being an oral and maxillofacial surgeon, I believe that the triple O's form one group. It's one subject for me, whether it's oral surgery, oral pathology, oral medicine and radiology. To an extent that when I was principal, we used to organize joint PG sessions. Whenever there was a pathology case in the oral and medical department, PGs from oral pathology as well as oral surgery used to join them right from day zero. I mean, when the patient has just walked into the OPD, that they used to see the patients together, take the patients together for further imaging and all those things, be together while the patient is being operated, and be together even in the oral pathology department to see what goes on with the tissue that has come through. So, that used to give a very holistic approach to the whole topic. And that's what I'm happy that those students who were there at that time benefited from this. So, with that, I believe that I'm also an oral pathologist in addition to an oral and maxillofacial surgeon. Anyway, coming back to the topic, let me share the screen. Is it visible? Part of it is getting cut by.
No, it's visible, sir. It's visible.
It's visible for everybody. Thanks a lot.
Yes,
Thanks a lot. Thanks a lot again. Anyway, I'm here to talk about management of systemic emergencies, because emergencies, I believe, can occur in any way. They can be systemic emergencies. They can be local emergencies like local pain, fractured tooth, and such things. So we are not here to talk about those things. We are here to talk about only when an emergency strikes the whole body, systemic emergencies. First of all, once again, my gratitude to Dr. Bhuvan, Dr. Nidhi Jadhav, who would be or is already the moderator here for this session, all faculty colleagues who are here, delegates who are here, POPMA members, and one and all here. My thanks to everybody here. What is an emergency is something that is described in different terms in various regions, various books, various authors, various speakers. For me, it is an unexpected and usually dangerous situation that calls for an immediate action. That's all. So an emergency can be anything. It can be a financial emergency. It can be an emergency, for example, a child just running across the road when you're driving in a car. All these are emergencies. So it's an unexpected situation and definitely usually dangerous that calls for immediate action. That's the reason why here we have a lot of books written on medical emergencies, on systemic emergencies during dental practice. So that is the importance of this topic. I happen to be with the world #1 in dental emergencies, and that is Stanley Malamed, when the FDI conference was held in Delhi in September 2014. So I happened to chair the session when Malamed sir was speaking. So it's a proud moment for me and my students and everybody there, whom you can see in the fourth slide there. Why is it important, or how much is it important? It's not that emergencies can never strike. It's good that they don't strike very frequently. So as you can see in these references, and on an average, a dental practitioner will experience a medical emergency at least once in 2 years, or somewhere around one case in 3 to 4 years, depending upon, various authors have written various things. All of us have come across emergencies when you have crossed a number of years of practice. So even in the early years of practice, you need to be aware, you need to be prepared for these things. That's the very crux of this talk here. Be prepared. They won't warn when they come or give you time. How do you prepare yourself? These are certain risk preparedness for emergencies, the basic steps. You need to take a good medical history. Don't cut short into taking medical histories of any patient, even if the patient is just for a simple filling. Assessment of patient for recognition of emergency and its possible cause. Resuscitation and remedy measures should be available. Emergency drugs and devices should be always there with you. And you should be ready to call for medical assistance by keeping a directory of medical services who can immediately respond to your call and such things. So ensure minimum competence from yourself and ensure minimum number of equipments that need to be there with you. No matter how much you're prepared, one thing I can say, preparation for emergencies can never get over. There's no end to it. But one basic minimum competence or minimum amount of preparation is required so that you can immediately recognize the emergency, think what can be done, and do it immediately. It is impossible for anybody to be adequately prepared to deal with every emergency situation. But then at least basic life support should be handled by each one of us. What are those parameters that you need to know about? while assessing emergencies. These are called C, T, P, R, and BP, the basic vital statistics of emergency of people. C stands for consciousness. First of all, you need to know whether the patient is conscious or unconscious or semi-conscious or what. Simplest way, I'll go on and tell you what it is to do it on an AVPU scale. More elaborate scales like Glasgow Coma scale and such things are available for hospital setups. But in the dental clinic, I believe even a simple AVPU assessment is very good. Most 99.9 patients of ours are fully conscious. So we are not worried, but we are worried about those people who are about to lose consciousness. T stands for temperature. Sorry. This table shows us some normal values which we all are aware of. And today, after the COVID, we all know that a non-touch thermometer is the best way to assess the temperature while being in your clinics. So you can easily reuse it n number of times without worrying about infection. P stands for pulse. All of us know where all pulses can be measured. And for all practical purposes, for us, the pulse measurement is made at the wrist, and that is the radial pulse. So that is what we normally rely on. Pulse tells us how fast the heart is beating, and that's what is important. One more important parameter here. Respiratory rate is important. And remember, we have pediatric patients, we have adult patients, so we need to be slightly aware of what is the normal respiratory rate in different age groups. BP is obviously blood pressure. Almost all of us know about blood pressure, so I'm not going to talk much about this. So that means that we need to do a rapid assessment of all these parameters whenever we think that there is a likely emergency arising. Additional assessment like lip color, conjunctiva, skin color, nails, the nail bed, posture of the patient, gait of the patient, whether the patient has been able to walk easily or not, and such things. So that's one main reason why all of our patients need to remove lipsticks and remove nail polishes while walking into the clinic. So that is one thing which I always tell my patients before they walk in and sit on my chair. That is where you can probably, those are the earliest sites where you can assess that, yes, something is possibly going wrong. A pallor, a cyanosis, all these things are easily visible there, though once you open the mouth, even the tongue color and gingiva color and all these things tell you more about these things. So let us see. Most of the books on emergencies, most of the lectures taken on emergencies talk about emergencies in terms of their diagnosis. For example, you talk about cardiac arrest, you talk about bronchial asthma and such things. Emergencies don't come with labels. They come with symptoms and signs. So I am trying to go from that point of view as to how it can be useful if I talk about symptoms rather than what diagnosis is the emergency about. As I said, systemic and regional emergencies can occur. We are not here to talk about regional emergencies. We are basically here to talk about systemic emergencies today. These are some systemic emergency symptoms that may come up when you face it. The patient may start getting dizzy. Patient may exhibit chest pain, breathlessness, sudden rashes appearing on the skin or on the face or inside the mouth as well, sudden swelling coming up, vomiting, abdominal pain. Patient may have seizures, cardiac arrest, obviously, because it is a symptom which is very unique, so we put it as it is, and high fever. So when such things occur, obviously they constitute systemic emergencies. Let's take them up one by one. What if your patient faints? Now, what is fainting? Fainting is loss of consciousness. So that is the reason why we measure consciousness initially. Okay. So loss of consciousness can be up to various grades depending upon what symptoms are exhibited by the patient. Common causes: vasovagal, orthostatic hypotension. When the patient gets up, the patient becomes hypotensive and loses consciousness. Epilepsy and other such neurological system problems do give rise to faintings, cardiac syncope, and psychogenic attacks. In dental clinics, it is often the fear and anxiety associated with the procedures, with the instruments, the equipments, and the way you stand in front of the patient. And that is the reason why I always discourage parents of my pediatric patients that they should never scare the patient in by the name of the doctor or the police. So when the situation does arise, the children don't approach these people well. So that is the reason why that should never be done. Factors to consider: if a patient is losing consciousness, if the patient is not able to speak, you need to talk to the attendant of the patient about when the patient ate any food, whether any previous medical condition that the patient is suffering from, like diabetes, what medications the patient is taking. All these things are better obtained initially itself when you take up the patient. I always consider it best to spend just 1 minute with the patient in your office before you take him into your clinic or on the dental chair. Or even if you've taken on the dental chair, do go into these details. Take just 1 minute and note them down if there is something of that sort. It helps. That time, it may not give you enough time to manage with those things. And coming back to the scale I was talking about, I told you about the AVPU scale. A stands for the patient is fully awake. V, patient is awake but may not be fully awake, but patient is responding to verbal stimulation. For example, if you tell the patient to open the mouth, if the patient is seemingly dazed but is still able to follow your commands, he or she is in V stage. Patient doesn't respond to verbal stimulation, but patient does still respond to painful stimulation, is where it is P. For example, the patient is unconscious, patient has fainted, patient is not able to listen to what you're saying. But if you pinch the ear lobule or under the nose, the bridge of the columella part of the nose, and the patient wakes up, opens the eye, that means the patient is still responding to painful stimuli. That is in the PU stage, P stage. And U is when the patient is entirely unresponsive. No matter what you do, even painful stimuli, splashing water, pinching the patient, none of that is able to bring the patient to respond, is where it is in the U stage. So it's a very, very simple stage, simple scale that is useful in our clinics. Hospital setups in such places, they go into more elaborate scales like the Glasgow's comma scale. I'm not going to go into the details of that right away. What happens? Or what do you do when a patient has fainted? First thing, lower the chair to a near horizontal position if you're not operating in the nearly horizontal position. It is wise to keep the patient almost horizontal while doing everything. Of course, taking care nothing drops into the patient's throat. Allow fresh air to come in. Open windows, open doors if they are not. Administer oxygen. We put it in red here because you'll find this almost everywhere. So it is very wise to keep oxygen available in your clinics. How we will do it, we'll see towards the end of the presentation. Loosen the patient's clothing. Keep vigil on the vital signs. It is always good to have a pulse oximeter. It is a low-cost, small device which can easily apply to the finger, the thumb of the patient, and keep a watch on the pulse rate, the respiratory rate, everything, the oxygenation and all those things. Use strong smelling substances to try to stimulate the patient out of faint. What are these small, strong smelling substances? Traditionally, people have been using cut onions and such other strong smelling substances, but it is next to impossible to have these in our clinics. In clinics, one advice is that you should have something strongly smelling like, liquor ammonia and such things. But then these days, this is not the practice. But simple eugenol itself is quite strongly smelling. Even a drop or two of eugenol in a small cotton pledget and used near the nostrils can arouse the patient out of unconsciousness if the patient is in that stage. Do not try to feed anything. It is very common for bypassers when there is somebody has fainted on the road. They try to give that patient water and such things. Never do that because the patient can aspirate these things into the respiratory tract, complicating the situation further. Abandon or defer your clinical procedure. By the word defer, I mean defer at least for that day. It's not that you defer for 5 minutes, 10 minutes, and then you take up the patient for the same procedure. Don't do that. because you need to refer the patient to a physician to make it sure that whatever small fainting has occurred is nothing else but simple vasovagal syncope. If it is simple vasovagal syncope, it's okay. It's good. We want our patients to come back to us with the report that it was just a vasovagal syncope. But what if it was cardiac syncope? What if it was something else, neurological? So that time taken will be 1 day. So call the patient again the next day if the patient is fine after visiting the physician. Chest pain. This is a symptom that brings a lot of worry to all of us. Not all chest pains are heart attacks. So one should be aware of these things, but still we need to take it very seriously as to what the chest pain is about. Common causes are cardiovascular, respiratory, gastrointestinal as well, and chest wall muscles, psychological, and other problems which can cause chest pain. What do we do when a patient comes to us and patient is sitting on the chair and has suddenly started saying, I'm having chest pain? Make the patient lie supine and relax again, horizontal position. See, administer oxygen has come back again, and that's why it's in red. Try to detect possible cause, but it is impossible for us. We are not physicians. We don't have enough equipments with us to try to detect what the chest pain is about. Diclofenac sodium, either given intramuscular or even in the form of a tablet, if the patient is able to take, is good enough. But at least it will tide over the immediate problem of pain, even if it is cardiac in origin. If you have nitroglycerin and if the patient has given you history of angina, the patient's blood pressure is high, it is worth trying with nitroglycerin kept sublingually into the patient's mouth. Call for assistance. Obviously, an ambulance may be required for such a patient. Patient with an intense chest pain may not be able to walk on himself. Do not continue treatment even if the patient reports now I'm comfortable. Refer the patient again, just like in unconsciousness. Do not give stimulant beverages. It is very common for people to mistakenly saying he had chest pain, but now he's all right. Give him a cup of coffee. That's the worst you can do. Because if it was angina, a stimulant beverage will again precipitate an attack of angina. So never do that. Breathlessness is the third important symptom that the patient may suddenly speak about. I'm breathless. Bronchial asthma, cardiac asthma, chronic obstructive pulmonary diseases, tuberculosis, foreign bodies, trauma, edema, trauma patients with edema in the throat, anxiety are all possible causes of breathlessness. What do? Ensure that the patient's airway is clear. You have not left something inside the patient's mouth. You have not kept a rubber dam in. You have not kept a big cotton ball in, which can occlude the throat and cause, an unclear airway. Administer oxygen. So I'm just stressing on this because this happens to be one thing that can tide over your crisis. So that is the reason why oxygen should always be with you in the clinic. An inhaler or nebulizer, if the patient is already using one, you can easily tell the patient's attendant, if the attendant has brought it, to immediately use it. What can you do? Administer steroids, anti-inflammatory steroids like hydrocortisone and dexamethasone. Hydrocortisone is preferable because it acts immediately. Dexamethasone may take just a few minutes more then because it acts on a different axis there. Deriphyllene is a common term used, a common injection which is used for opening up the bronchi as a bronchodilator. It contains theophylline and etophylline. Adrenaline 1:1000 also is an important one in terms of a drug which can immediately open up constricted bronchi. Adrenaline opens up bronchi. So one has to remember that though it may constrict blood vessels, it opens up bronchi. So that is the reason why adrenaline 1:1000 should always be available in your clinic. It also happens to be a miracle drug for allergy. So for breathlessness and allergy, it's something that works remarkably well. It has a very short shelf life. It lasts only for 1 year. The shelf life is 1 year. Expiry date is just 1 year from the date of manufacture. So you need to keep on buying those things. You need to keep a tab on what is the expiry date of all these drugs and keep on buying them. Doesn't matter. It's an insurance policy that you need to buy. Stop your procedure, refer or call for assistance if the patient is still breathless. Stomachache. is the next symptom that the patient may suddenly say that I'm having intense or severe stomach ache. What do you do about? These are the traditional areas of the abdomen and the possible causes of pain or possible problems associated with every symptom. I'm not going to go into the details of this, but it is something which is worth reading about. It is very commonly available in most of the textbooks of medicine. What do you do? The simplest thing you can do is to give the patient an antacid immediately. An antacid like Gelusil or anything of that sort. If you have liquid, it is best, because what I do is I feed the patient half a bottle of Gelusil, the normal medium-sized bottle, half a bottle of it. It doesn't cause any harm, but it gives a lot of comfort to the patient, because most of the abdominal problems are associated or start with acidity. So an antacid always helps. Antispasmodics, like there are so many antispasmodic, I wouldn't like to take trade names here, but then Meftal Spas is one antispasmodic which works miracles in abdominal pain. Diclofenac sodium, if you're not sure. Antiemetics, if you think the patient is already having nausea along with stomach ache, antiemetics can be given, and definitely call for assistance, abandon your treatment, call the patient the next day, refer to a proper physician. Now, this is what one needs to be very sure about. A sudden rash appearing, sudden red spots, red patches, macules, papules, and all these things occurring on the skin, around the mouth, inside the mouth, and everywhere. You need to think about allergy first of all, beyond all other things. It may be infections, it may be anything else, but then allergy is the thing that needs to come to your mind immediately. The common allergy trigger is often said to be lignocaine, though till date, in so many years of my practice, I passed my BDS in 1984. I've been in the clinics since 1982, 1983. Since then, till date, I have not seen a single patient allergic to lignocaine. Though definitely the books say that there are. It doesn't mean that there are no patients allergic to lignocaine. I need to stress about how do you test that. If the patient says, or if the patient suddenly has a rash when you administered this, if you have already given the injection, there's probably no point in doing an allergy test for that patient after which. So you need to take other measures. But if the patient says, I'm allergic or I'm possibly allergic to lignocaine, this is how it is done. Pinch the skin of the forearm, pinch it up. Administer 0.2 ml, just inside the dermis, just into your pinched skin. Mark the site with a circle, note the time of administration. Note it for at least 30 minutes for erythema, rash, or a swelling coming up in that same area. Such things, if they don't occur in 30 minutes, it means the patient is usually not positive for allergy to lignocaine. But one must practice this with caution. Remember, an allergy always comes back with several times the force the second time, the second exposure to the same allergen. In the first exposure, it may come up as an allergic response. Second exposure would probably be fatal. So you need to be extremely cautious about these things. If the patient has already got exposed to it by your injection or something, and if the patient, don't try to do an allergy test, because that may be a second dose for the same patient. What do? You need to have injection chlorpheniramine maleate, that is AVIL, hydrocortisone, dexamethasone, and adrenaline, as I said, is a very strong anti-allergic medication. Hydrocortisone and dexamethasone, or hydrocortisone or dexamethasone, is something that one should always have. Even if you don't have AVIL, if you don't have adrenaline, it doesn't matter, at least these things will immediately start acting. So there are two things. I'm prematurely saying this in between my lecture here. There are two things that are extremely important when you talk about dealing with medical emergencies. One is dexamethasone or hydrocortisone, any of the anti-inflammatory steroids. And the other is oxygen. If you have these two, it's almost 90% of your medical emergency kit. Oxygen definitely helps. Stop further treatment, call for assistance. Seizures. sudden convulsions that the patient exhibits while sitting, while sleeping on the chair, while lying down on the chair, getting treatment done. Stop your procedure. Take your hands out of the patient's mouth or be ready to get bitten by the patient. These are the possible causes: epilepsies, adverse drug reactions, substance abuse if the patient has got exposed to these things, and several other systemic problems that may bring about seizure. Now, in a clinic, it is impossible to go into details of these and stop looking at the patient. So, first of all, we need to do something about it. What do? Protect the patient, protect yourself. By protecting the patient, by writing down protect the patient here, fortunately, our patients are lying down on the dental chair. So they are already in a protected position. Just see that they have not, got up or something of that sort. They are walking into your clinic and having a convulsion. If that is so, immediately make them sit or lie down on the dental chair so that they are in a protected position. Protect yourself, as I said. Make use of a mouth prop. A mouth prop immediately inserted in between the molars will at least protect the tongue of the patient, protect yourself from getting bitten and such things. Stop your procedure. Administer. Previously, it used to be diazepam, which was a drug of choice for all these things. But today, with diazepam placed in a list where it is not very easily available for us, midazolam comparatively are still available even in the form of syrups or injection. You can give it to the patients, and the patient will slowly go into a calmer posture from that convulsion, regardless of what is the cause. Call for assistance and refer the patient to a proper physician or the treating physician. And airway is what is seen here in addition to mouth props. The airway also ensures that the patient's airway is intact. But it is very difficult for an untrained person to put an airway inside. Let me just talk about a little about putting the airway inside the patient's mouth here. An airway goes from the lips till just behind the tongue. So a very conscious patient may not allow somebody to put an airway. He'll gag. He or she will gag. It is only the semi-conscious or unconscious patients who will allow an airway to be put inside. The airway is always inserted with the tip pointing up. That is the other way around. Once you've taken it into the throat, when you've reached just at the throat, at the base of the tongue, you turn it around and then insert it further. Trying to put it directly will, clump the tongue behind and not allow you to put the airway inside there. Just a small technical note on putting the use of the airway here. Stroke. What is a stroke? A stroke is something like a brain attack, just like a heart attack. A part of the brain is not getting full blood supply. A stroke is what occurs. Infarction results later after that. Two types, ischemic and hemorrhagic. Both these things act in a slightly different way, but the symptoms are usually common. So that is why for us, it doesn't matter whether it is ischemic or hemorrhagic stroke. Patients with history of hypertension, diabetes, smoking, increased cholesterol in blood, taking oral contraceptives, long bone trauma. Why long bone trauma? Because long bones have big marrow spaces, and usually adult patients have a lot of fat in the marrow spaces. This fat is released into the blood vessels once a trauma or fracture of a long bone occurs. And those fat globules travel around the bloodstream and may get, they can obstruct either a coronary artery or a brain artery, resulting in stroke or a heart attack or whatever. So that is why the first 1 week after a long bone trauma is very important, though the patient is not having any other head injury or anything. That sort of thing. How to recognize? This is very important for each one of us. There was a patient, not a patient, actually a relative of mine, who spoke to me from approximately 20 to 30 kilometers from my clinic. And all that the patient was saying is that I'm not feeling all that too well. But the way the patient was saying that made me tell him, you give your phone to your driver immediately. As soon as the driver took the phone, I told him, you rush to so-and-so hospital or so-and-so clinic before anything else. What did I hear? I heard that the patient was not very coherent in his speech. Patient was having a slight slur, as if he had drunk a little bit of alcohol. So that's sort of a slur without having any other influence is most likely to be an impending stroke occurring there. So these are some signs: loss of balance, blurring of vision, face getting slightly asymmetric, arms getting asymmetric, weakness is one side of the arm or the leg, blurring of speech difficulty, it is best to immediately call for help. The patient needs to see a proper hospital setup as early as possible. The first 1 hour is very, very important. In fact, the first 30 minutes are very, very important for our stroke patients. Now, that relative of mine happened to be taken to a doctor, was given immediate attention, and recovered completely, and was told that he had a stroke attack there. So that sort of a time is what is important. Time is important for this. Recognizing the stroke in time, timely referral is the key to 100% recovery. Treatment started within 3 hours are shown in studies to have resulted in almost 100% recovery. But let us not take it as 3 hours, let us take it as short as soon as possible. Cardiac arrest. This brings us to a very, very important topic. Commonly, terms like cardiac arrest, heart attack, cardiac failure, these three terms are usually used, for one another. They are confused. So let us not have any confusion as doctors, though we've studied it, but let me just, revise it for all of us. Cardiac arrest simply means that the heart has stopped. Okay, so that is cardiac arrest. What is heart attack? Heart attack is where a coronary artery has got blocked and the patient is having a sudden, sharp, very intense pain in the chest. That is heart attack. And what is heart failure? Heart failure is where the heart is functioning, but it is not functioning to the full extent, like ventricular failure and such things, where it is not pumping fully. So the patient is having venous pooling, swelling in the legs, dyspnea, pulmonary edema, and so many other things, which are all signs of pulmonary, cardiac failure. So that is the distinction. So coming back to cardiac arrest is when the patient does not exhibit pulse, when the patient has no heart sound when you auscultate the patient, and if you happen to be connected, the patient happens to be connected to an ECG, a fibrillation or a flat line says that this is cardiac arrest. Now, this is the importance of knowing what is cardiac arrest and why and how do you do. A CPR is cardiopulmonary resuscitation. It can never be overstressed if I say every one of us needs to be trained in at least basic CPR. So many instances on the road, in the airport, inside the flight, in a train, people have suffered cardiac arrest, and just because somebody happened to know something about CPR, the patient's life was saved. So these are certain examples of all those things that have happened. That patient, what I want to stress is what is seen in blue underneath there. The patient said, you always hear about CPR your whole life, but in the back of your head, you're like, oh, I'm not really ever going to use this or make use of it. But the patient whose heart had stopped and was saved by somebody who knew CPR then went on to say, I just can't believe that it saved my life. That is the importance of CPR. It happens everywhere. Taking note of this, Venkaiah Naidu, who was our former vice president, had ruled that the Indian Resuscitation Council trains almost everybody. Look at the statistics. How many cardiac arrests occur in our country? Well, USA has only a small number compared to that. But so that is why now these email IDs and mobile numbers are of this council, who offer training at highly subsidized rates for anyone who approaches them. This is just the chart of an adult CPR and a child CPR. It is beyond the purview of this lecture to describe that in detail. But all it suffices to say that you need to have a frequent compression of the chest to such an extent that the heart also undergoes compression, along with a respiratory assistance, if possible, with an ambu bag or a mouth-to-mouth or a mouth-to-nose respiration. Okay, so in a clinic setup, that is about which we are talking about, we need to have an ambu bag with us. It is a very, very simple device, but it comes in handy, extremely important to us. And if coupled with an oxygen, it works like miracle. You should you should know that in infants and childs, you don't put same amount of pressure, or you don't use the whole fist or the whole palm for doing a CPR. This is something that I need to stress upon, that these days automated electrical defibrillators are available at public places, airports, important railway stations, important malls. You may find these machines which have been put up there. As doctors, at least, we need to be slightly aware about what to do in a patient. Turn the AED on by pressing the on button. Once the AED is on, usually all these AEDs have voice assisted prompts to tell you what you should do, where you should place the pads on the person. The device will analyze on itself and give a shock as per requirement of that particular patient. And you may be the agent who has brought in a difference between life and death for that particular individual there. Same thing holds true in clinics, but it is next to impossible for all of us to have an AED in our clinics. But you should be aware about it. Fever is one more emergency symptom. Anybody who reports fever, that is something that you cannot, ignore. Normally, fevers are because of infections, heat exposure, and so many other things, even medicines. Measure the temperature. Simple paracetamol syrup, tablet, or injection is a drug that often doesn't have any major problems when administered. You can always give the patient this, and again refer the patient. For us, a fever suddenly appearing may be a different sign. A patient is having a dental infection. We are treating the dental infection. We don't know whether the dental infection by some or the other means has precipitated a meningeal infection for that patient, and the patient has suddenly started. We should be aware of these things. Vomiting. The patient is on your dental chair and suddenly starts vomiting. That sudden vomiting is an emergency. A routine vomiting, if the patient already says, yes, I'm a gagger, I vomit frequently, that's not an emergency. But a sudden vomiting is an emergency. You need to note that these are the things which are possible. Medicines, anxiety, head injury, simple gag reflex or gastroenteritis and foodborne illnesses can bring about gagging and nausea in these patients and resulting in vomiting. What do you assess for? Color of the vomiters, contents of the vomiters, whether it is food, whether it is blood, whether it is pus, whether it is anything else. Quantity, mechanics. Mechanics means how is the vomiting? Is the vomiting, projectile, like the vomiters is just flying out of the patient's mouth? What are the history symptoms of that patient? What do you do? Position or the patient to prevent aspiration. What is aspiration? Aspiration is anything that enters into the respiratory tract except air. So we don't want anything else to enter into the respiratory tract. If the patient suddenly vomits and the patient is not fully conscious, the patient may take in part of the vomiters into the respiratory tract. That will drown the patient inside that, within the same vomiters. So we need to position the patient immediately. How do you do that? You turn the patient 90 degrees to any one side immediately, as early as possible. So that even if the patient is vomiting, the vomiters is just going out and not entering into the throat and into the respiratory tract and such things. If the patient is totally unconscious, you will have to assist in turning the patient and seeing that this occurs. Assist in clearance. Your simple suction can help in immediately clearing whatever is there in the mouth or in the nose. After the patient has stopped vomiting, you can give antacids and antiemetic medications for these patients. Defer your procedure. Instruct on timing and quantity of food while coming for dental treatment, especially in those patients who are gaggers. This is an important thing which you should be always aware about, because this is an emergency that can exhibit in any way. It can cause chest pain, it can cause unconsciousness, it can cause blurring of vision, it can cause rashes. So many things can occur with drug interactions. And when I say drug interactions, it's not only drug interactions, it's also interaction of drugs with other things like herbals the patient may be taking, the food that the patient may be taking. A drug may particularly interact with the kind of food. So all those things are important for us to know. I did not find any good statistics in the Indian scenario because not much of it is kept tab about. So in the US, this also is an old reference here. This is the intensity, or this is the frequency with which drug interactions cause certain symptoms here. As I said, drugs interacting with food, with herbals, the environment, body. We are giving so many drugs to our patients. Have we ever assessed, are any of these drugs going to interact with what the patient is already on? Patient may be on some antihypertensive, anti-hypoglycemics, even for that matter, just simple contraceptives. Just to give you an example, tegretol, the carbamazepine, interacts with contraceptive agents. So these sorts of informations basically should be there. But when you prescribe, today it is very easy for us. Previously, there used to be books on drug interactions. People had to refer to these books to see the possibility of drug interactions between whatever you are prescribing the patient. Today, it is very easy. Mobile apps are available. Medscape is one good app that I have found useful. In Medscape, there is a drug interaction tab. If you click on that tab and you enter those drugs that you're prescribing to the patient, the app immediately tells you whether there is a possibility or a potential for drug interaction. And if there is, what level of drug interaction? Is it going to be life-threatening? If it is going to be simple, mild interaction, or what kind of interaction? Make use of these apps. These will save you time. So far, we've seen things which may occur with the patient. Emergencies can occur with you also in the clinic. So you need to be aware of that too. And one biggest one is faint. When the doctor starts feeling faint, don't become a hero by continuing the procedure. Stop the treatment procedure. Call for assistance. Tell the patient, I'm not feeling all that too well. I'm not happy with the way things are going. Please come back again someday later. Tell your assistant to help you, take you to the nearest medical center, or call for assistance. Call for some medical practitioner who may be able to come immediately and attend to you. That brings us to the end of talking about the symptoms and signs that can occur, which may comprise emergencies, medical emergencies, systemic emergencies. So let us talk a little bit about what should we have in our clinics. What I have is this, what I've written here. What you can have is at least those things which are seen here in red. Injections like hydrocortisone, dexamethasone, which are life-saving steroids. Adrenaline, as I said, extremely important for allergy as well as bronchospasm. Chlorpheniramine maleate is able. Midazolam injections, theophylline, etophylline, that is deriphylline injection, diclofenac sodium injection, and hemostatic agents like stadrin, ethamsilate. There are so many of them. I can enumerate them, but at least one of them should be there with you, which you can immediately administer. Ethamsilate is something so good that it can be even, an ampule can be broken and the contents in the form of ethamsilate solution can be soaked in a piece of gauze and pressed upon that area which is bleeding. Even that stops. So it can be a topical as well as a systemic agent. So ethamsilate is the best thing to have in your clinics. Equipments like pulse oximeter, sphygmomanometer, these are all digitally available today. So it makes things much easier for us. Thermometers, glucometers, oxygen canisters. Let me just make a small note on this. If you can see the figures down there, in even sites like online shopping sites like Amazon, you can get these small oxygen canisters in a comparatively low rate. But when it comes to saving a life, it becomes extremely expensive for us. You need to have these, at least the small ones, if not the bigger ones. The one which is seen as 16,999 is the optimum one. But then not all of us can afford this. Or not all of us can immediately, prioritize buying oxygen to such an extent. It may not come in use at all. So it is worth having these smaller canisters with us. It helps immediately tide over the crisis. Abbey bags, as I said, and other tablets and capsules, sugar for those who may have gone into hypoglycemia, and other necessary items which are already there, but it should be there in a particular place where you can immediately approach it. And when you have injections, mind you, you should also have the ampule saw. Now, there are good ampule saws available on Amazon and other things which are very convenient to use. And you don't even hold the ampule with your hand. There are slots made into that where the ampule is there, so you don't cut yourself. Otherwise, breaking an ampule is something which can result in you having an injury in your hand. So that has to be taken care of. and most importantly, a directory of physicians, surgeons, and hospitals in your vicinity with phone numbers where they can be immediately contacted, stressed upon, and you should also have numbers of good ambulance services around you who can immediately come to you and take the patient to a proper hospital. So, this is something that I need to stress upon. Thanks a lot for the patient hearing. I'm extremely happy to be of some use, if at all. I'd like comments on this, and I'd like definitely invite questions if there are. And if I can answer, I'll definitely do it. I'll just end it up with saying even a cardiothoracic surgeon on the road may not be able to help a cardiac patient. So you need to be equipped for that. So don't blame yourself if you have not done something, but then it is always good. You'll be happy if you have done something about it. Thank you. Thank you once again.
Thank you so much, sir, for such a wonderful lecture. Big round of applause for you.
Thank you.
Now the podium is open for discussion and questions. And I'll just change the setting. Those who want to ask by themselves, that they also can do.
Anybody who would like to ask something, unmute yourself and do ask.
Yeah. You can unmute and you can ask, sir. A lot of good comments, sir.
Yeah, I am seeing those comments on the messages. Excellent.
Yes,
I'm really happy.
So yes. I want to ask one thing.
Sure.
So it was very informative lecture. Thank you very much, sir, for such a wonderful session. So actually, I want to ask you if any lady comes in first trimester of pregnancy, and if she goes in syncope, first trimester of pregnancy.
If you know that the patient is, what would you like to ask here?
What precautions we should take if she goes in syncope?
Yeah, if you already know that the patient is in the first trimester of pregnancy, and if you already know that the patient has gone into syncope, here at least we don't have the uterine contents which are potentially possibly going to press upon the inferior vena cava or anything of that sort. The weight is not that much. So the posture of the patient is not all that important here, but still we don't do an entire supine positioning here in the patient. Oxygen is the best thing in whatever position the patient is in. While doing your procedure, if you feel that the patient is going into syncope, stop the procedure, take out everything that is in the patient's mouth. Well, all of us know that in the first trimester of pregnancy, patients usually suffer from nausea, from vomiting, and all those things. So those things can be precipitated. So your precautions should be more directed towards that. Otherwise, it's not all that gravid situation here. Any experience that you are able to talk about or anything of that sort, anything pointed, will be more appreciated here in this question.
Dr. Shipra, ma'am. Okay, I think we have lost connection, sir. One question is there by Dr. Ayaz. What is the best test to diagnose skin allergies after dental treatment? Who is on bronchial inhalers?
Bronchial inhalers? I'm sorry, I'm not able to get your question about
the question is, what is the best test to diagnose skin allergies after dental treatment? Who is on bronchial inhalers?
The patient is already on bronchial inhalers. So see, a skin allergy, or for that matter, any allergy, we don't talk about the best test because it is such a wide range of things that can cause allergies, ranging from contact dermatitis till frank pruritus and everything which can occur on the skin because of allergies. No single test will tell you, but you can always diagnose allergy by going into ESR and other allergy tests, pointed allergy tests for things. People have gone into extensive allergy tests for so many other things. During dental treatments, it is not you who are precipitating allergy. It is something that the patient may have taken or something of that sort which can cause allergy. As I said, lignocaine is the most frequent drug we are using. Most of the other things we are using are not all that allergic, but lignocaine definitely is something that is always told to be allergic. But as I said, it is extremely rare. So in such a patient, you don't attempt another test here, but you send the patient to a physician who can take care of the symptoms first, and then, conduct investigations to find out why such an allergy has occurred. Right from, ranging from simple ESR till ANA and all those pointed allergy tests. I hope I've, made it clear from a practical point of view. I'm talking mainly from practical point of view. Yeah.
Yes, correct, sir. Very right. He's saying thank you, and a lot of good comments, sir. Very informative session, and everybody is happy. Any more questions? Anybody would like to share any of their experience or?
Good afternoon, sir. This is Dr. Abhishek Badrana.
Hello.
Yeah. So wonderful lecture again, sir.
Thanks,
in a patient who has had syncope because of the vasovagal syncope, he's scared of the procedure. You actually stop the procedure and you want to call him back. Would you give him Angsit or something, sir, for the next appointment?
Absolutely. I was just going to tell you this. If the patient is a frequent, person who can, potentially go into vasovagal syncope, first of all, very few patients go into vasovagal syncope in the horizontal position. It is almost non-existent. So once you put the patient on a horizontal position while treating, and that was the very basis of getting in physiological chairs. When we were students, we were not using physiologic chairs. We were using those chairs where the patient's backrest was upright almost. So once the physiologic chairs came in, this was the very basis of it. If you keep the position on physiological chairs in a horizontal position, it is extremely rare. First of all, reassurance is an important thing. Anxiolytics definitely have a role, but then treat it with caution, because these days prescribing anxiolytic itself is an anxiety for the doctor more than the patient. So you have to take it seriously that what you're prescribing, the patient may reuse it on himself or herself. You wouldn't know. The patient goes to different chemists with the same prescription, buys a lot of them. If something happens to the patient, it is your prescription which comes in. So anxiolytics, yes, they have a role, but it is best prescribed by you with the consent of a physician. So more than that, reassuring the patient, keeping the patient in a proper supine position and treating the patient with reassurance and everything takes care of it. Anxiolytics, yes, as I said, small quantities probably you may dispense rather than giving to the patient, but with the patient having the information that you've given the patient this medicine, that has to be written on the patient's case slip that you have administered this particular drug for that patient, whether it is lorazepam, whether it is clonazepam, whether it is something else you've given. It depends on you.
Okay, sir. Thank you so much.
Thank you, Dr. Abhishek.
Yeah. Anybody would like to ask any question or any queries or? Okay. So I think no further, sir, no question is there. Okay, sir. Then we'll wrap up and.
Thanks a lot. Thank you so much.
Yeah. Yes. Thank you, sir. On behalf of POPMA, I extend my heartfelt thanks for your inspiring session at POPMA Study Club and your insights from decades of your clinical experience, academic leadership, and
I tried to keep it basic and practical rather than going to the theory of everything.
No, it was indeed, sir. It was an honor to learn from someone from your stature, sir. And we are deeply grateful for your time, wisdom, and presence, sir. Thank you so much.
Thank you so much. Thank you.
And now I request everyone to put on their camera so that we can have a group photograph. And by the way, I would like to make a small announcement that POPMA is organizing its first national conference, that is POPCON, Practicing Oral Pathologist Conference 2025. and that will be on 4th and 5th of October. And yes, sir is also one of our guest speakers there.
Thank you again for that.
Yeah. So I request everyone to register and make use of that knowledge extravaganza for 2 days. And it is open for undergrads, PGs, and professionals. And yeah, I'll take a photograph. Any more would like to put on their cameras? Give one more. Yes. Thank you so much, and see you next month with some more new topics for August session. And once again, thank you everyone for attending, and stay tuned for the updates. Thank you so much, sir, for your
Thank you. Thank
time.
you so much. Thanks a lot, everybody. Thanks a lot, everybody, for the patient hearing, and I hope it was useful.
It was wonderful, sir.
Thank you. Thank you once again. I'll take your leave then.
Yeah, thank you, sir.